Welcome to Module U. We're going to be talking about mental health and mental illness. We're going to explain our role as nurse aides in what we call de-escalation, and we'll talk more about that. We're going to talk about anxiety disorders and mood disorders. And first, we're going to start off by defining a couple of key terms here. So mental health is our ability to cope with and adjust to everyday stresses in a way that society accepts. Mental illness, therefore, is a disturbance in this ability to cope or adjust to stress. Our behavior and functions become impaired. We may have mental disorder, emotional illness, or psychiatric disorder. I mentioned de-escalating. Well, de-escalating is when we cause something or someone to become less dangerous or less difficult. And we'll talk more about that here in just a little bit. When it comes to mental health and mental illness, it really is having great day-to-day relationships that are the key. They're the heart of de-escalation. When we're, especially being nurse aides, working with our patients as closely and as frequently as we do, we know what is normal for our residents and for our patients. So we may see those signs that a resident is beginning to become agitated or something's changing. We're going to be the first ones to see these little signs. So some causes of mental illness. There are physical factors for mental illness, and that could be or it could be a different illness that's causing some mental health issues. It could be a disability, aging, substance abuse, or just chemical imbalances. Environmental factors such as weak interpersonal skills or family relationships can also cause mental illness. Traumatic past experiences such as abuse, inherited traits, or just our ability or inability to cope with stress. Anxiety disorders. So generalized anxiety disorder is characterized by anxiety and worry in the absence of an imminent event. So there's nothing happening in that moment, but we feel anxious, worried, even so. Obsessive compulsive disorder is characterized by obsessive behavior or thoughts, which may cause an individual to repeatedly perform a behavior or routine, such as washing their hands over and over again, checking a door lock over and over again, etc. Post-traumatic stress disorder is brought on by experiencing or witnessing a traumatic event, such as a violent crime or combat in the military. A phobia. This is an intense, irrational fear of an object, place, or situation, such as flying or spiders, for example. Now we're going to talk about mood disorders. So those are anxiety disorders. These are now mood disorders. Depression. Depression may cause a loss of interest in activities that we once enjoyed, even things like eating or sleeping or work. Individuals with depression may suffer intense emotional and physical pain, and if it's left untreated, depression can lead to suicide, especially in the older adult. Bipolar disorder. This is a condition in which an individual has mood swings and changes in energy level, including their ability to function. So these changes in mood and energy level are so extreme that we become unable to function. Mood swings can alternate from extreme activity, which you may have heard called a manic episode, to periods of deep depression or a depressive episode. Schizophrenia. Schizophrenia interferes with an individual's ability to interact with others, make decisions, think normally, and communicate clearly. Individuals who experience hallucinations may even see someone or something that is not really there, or they may hear a conversation that is not real. Individuals who experience delusions may believe that other people are controlling their thoughts. And these are some of the common things that you may see in the schizophrenic patient. So mental health and mental illness can be treated in a variety of ways, and often it's going to be a combination of these things. So you've got medication, psychotherapy, cognitive behavioral therapy. It's important for us as nurse aides to recognize appropriate and inappropriate behavior. And when we see inappropriate behavior or something that's different from our residents' normal, or something that affects our patients' or residents' ability to function, we want to notify our nurse immediately. As we've already mentioned, we have probably the most opportunity to observe our patients and our residents, especially when we're referring to the long-term care setting. So again, we're going to see these changes the soonest, even when they're little and maybe not quite as noticeable yet. So de-escalation of a resident who is agitated. The first and only objective of de-escalation is going to be to reduce the level of intensity, right? Because we want to keep ourselves safe, we want to keep our residents safe, and we want to keep everyone else in the area safe. If we can de-escalate and reduce this level of intensity, we may be able to have a discussion with this person who's getting agitated, and that's really the goal. So there are some, I lost my spot, sorry. Okay, here we are. So some different behaviors are our role, how you're gonna see our behaviors, our posture, our body movement and facial expressions, our attitudes, our tone of voice. All of these things are gonna play an important role in our ability to de-escalate a resident. We want to appear calm and centered and self-assured, even if we are scared and not feeling quite self-assured. We want to present that kind of appearance. If we look or act anxious, that's going to make the resident feel even more anxious, which also makes them feel unsafe, which in turn is going to escalate the agitation. Our posture, we want to be at the same eye level whenever possible. So we want to encourage the agitated resident to sit down. We're not going to force them, but if we want to try and encourage that so we can sit down with them. But if they're standing, we're going to stand. Again, we want to try and be at the same eye level. We don't ever want to be over looking down on someone, especially. We do want to be alert in our posture, but still relaxed. So we're going to stand up with our feet, about shoulder width apart, and our weight evenly balanced, and avoid aggressive stances. And I'm probably jumping ahead here. We'll talk about these a little bit more, but you don't want to cross your arms. You don't want to put your hands in your pockets. You don't want to be pacing. You want to not make them think that you are upset either. We want to position ourselves for safety. We never turn our backs on an agitated resident for any reason. We maintain a safe distance of at least 2 arms lengths between ourselves and the agitated person. And that, of course, is so that if they were to take a swing at us, they wouldn't be able to reach us. I did start to mention this already. We want to kind of have our hands in front of us, arms, palms open. We want to appear non-threatening. And also when our hands are just relaxed and at our sides, if we do need to protect ourselves or block ourselves, it's readily available, right? If I had my hands in my pockets or behind my back, it's going to take longer. I might not be able to protect myself. Our body movement and language. So our body movement, if we're moving too much, that can indicate anxiety, and like I mentioned, can increase agitation. So we want to minimize our movement. Some of us have a tendency to talk with our hands or to fidget when we're nervous. You want to limit that. Avoiding the crossed arms or hands in the pocket, I mentioned that already. Refrain from pointing or shaking a finger. Hopefully you wouldn't be shaking your finger at somebody anyway, but just make sure to avoid that. And one of the key things with an agitated resident, even if touching that resident like on the shoulder or the arm is generally something that's accepted with them and okay, we don't touch the agitated resident. It's too easy for the agitated person to misinterpret that as hostile or threatening. We want our facial expressions to be neutral. We want to be calm, but really attentive. That can help to reduce that hostility and agitation. We want to make eye contact, but we definitely don't want to be staring down our resident. And we also don't want to never make eye contact at all, because then they can get that feeling that we don't care, that what they're saying is not important. And then, of course, if we're staring them down, that's very threatening to people. Our attitude is also really important. We have to try and remember in these moments when we have patients with mental health and mental illness who are getting agitated and escalating, we don't want to get defensive in these moments. That's going to not do good for anybody. So even if the comments or the insults are directed at you in particular, remember, it really isn't about you. It may feel like in that moment, but it's really not about a particular person. So we want to be respectful and set limits, or of course call for help when we need it. People who are feeling agitated are really highly sensitive to feeling like shamed or disrespected. So we need to make sure that we show them respect, even if they're in that moment not necessarily showing everybody else some respect. Now, you can set boundaries, and I'm going to wait on that because I'm going to give some examples of that as well in just a second here. Our tone, we want to keep our tone low and monotonous. When we get nervous, we tend to have a higher pitched tone, or when we're scared, right? So we've kind of got to work on controlling that. We don't want to try and be louder than the resident if they're screaming. So we kind of wait till the resident takes a pause or a breath and then speak, because we don't want to start escalating or raising our voice. Speak calmly and maintain that kind of average volume. And I mentioned our responses, okay? So we want to respond selectively. And what I mean by that is only answer informational seeking questions, even if they are asked rudely, okay? So if someone says, for example, why am I in this GD place, okay? Well, they might not have asked it in the most appropriate way, but it is a genuine information seeking question. So we can answer that question. Now, if the resident who is agitated says, why are all these effing nurses in this place terrible and mean? Well, that is not seeking any information that's going to be helpful necessarily. So we're going to not respond to that type of question. We do want to be honest. If we lie to a resident who's agitated, they're just going to lose trust in us, and then that's going to cause future agitations. I don't know if that's agitations, agitating situations to actually be worse if they have learned to not trust us or learn that we have lied about something. If it's directed by the nursing care plan, because residents who maybe have had a repeated behaviors like this, there may actually be parts in the nursing care plan that tell us how to address this or how things have worked well in the past. So we can explain limits, and we can do this in an authoritative and firm but respectful tone. That's really important. It's also really important, and we've talked about giving choice a lot in this class. If we can give a choice, give it. For example, would you like to continue walking calmly, or would you prefer to sit down with me? Do you want to sit and talk about why you're upset? We could get a cup of coffee or some juice. Which one would you like? We always want to empathize with our residents' feelings, not the behaviors, right? So we could say, I understand that you have every right to feel angry right now, but it's not okay for you to threaten me. That's a good example there. It's also a great idea to have alternative behaviors, right? So that would be like the example I used before. Would you like to have a seat and have some water or coffee with me and we can talk through this? And don't try to analyze or interpret how someone's feeling. Just acknowledge that what they're feeling is valid, and say that you're there to help and to keep them safe. Again, we're not there to try and convince them of right or wrong. We're not trying to convince them of how they feel or argue with them. We're there to be supportive. And again, I said safe, but I'm going to say it again. A lot of times these residents who have mental health and mental illness really just need to feel safe and secure. Again, if it's in the health or in the care plan, you can list some consequences. Sounds a little harsh, but consequences of inappropriate behavior in a non-threatening, non-angry kind of way, and express the limitations or the consequences that could happen are because of the facility rather than a personal thing between you and that resident or just that resident. It's important to remember when you have a resident who's getting agitated and who's escalating to trust your instincts. We can do what we can, right, to try and de-escalate the situation, but it's really important that if it's not working, don't keep trying and trying and trying. Just stop and calmly get some help. Now, there are some differences when we have a resident who is cognitively impaired, right? In trying to keep ourselves and them and others safe. We want to try and control the environment as much as possible. Like in this, some of this is going to be repeat for what we just talked about, but making sure we're standing at least 2 arm lengths away. Move others out of harm's way as well. So if they're in the activity room or the day room, for example, go ahead and get everyone out of that room, or have someone get them out of the room while somebody else or you are staying with the resident to make sure they're safe. Removing objects that could be harmful. Don't touch the resident, like we've already said. And again, making sure you're keeping them safe. It's really important, and this goes for all behavior, honestly, all behavior, our kids, our significant others, our residents, our patients. Look for the meaning behind the behavior. We want to address people's feelings, not just what they're saying, because again, when people are agitated, they can say a lot of things, but look for what they're feeling. What is the meaning behind their behavior? Pay attention to body language and facial expressions. And when we have these great day-to-day relationships with our residents, we may actually get some clues or have some ideas about what this behavior may actually mean. And sometimes it's checking for underlying causes, like they're in pain, they just started a new medicine, they're hungry and they can't express that to us, or they have a new illness like an infection. There could be social or emotional triggers as well, like the area was really loud or hectic, it got too hot or too cold, the daily schedule changed, and for someone who's cognitively impaired, that can be a big deal. We want to respond in the person's reality. Again, we're talking about patients with cognitive impairment here. So we can try some different things, right? We can redirect, and that's drawing attention to another subject. We can try and figure out what the trigger of the behavior was. And if we can figure out the trigger and we can remove it, excellent. We want to engage in the resident's story, but we don't want to, again, we want to be truthful. We don't want to make things worse. So for example, if the resident who is cognitively impaired and is getting agitated and says, I just have to get to work, I'm just trying to get to work, we don't necessarily need to say, Betty, you haven't worked in 20 years, you don't work anymore, right? We can instead say something along, Betty, I know you really enjoy your work, what do you do, or what did you do for a job? So just engaging with them with what they're feeling and thinking about, but not giving false information either. All right, let's see. Some points to remember here. So remember that residents are more than a diagnosis. A person with a mental illness is still an individual, of course, right? So not every resident who has depression is the same. Not every resident who has anxiety or bipolar is the same. They're all different, unique individuals. All behavior has meaning. If we can find the meaning behind the behavior, that's going to be key. In some instances where the resident has a cognitive issue like dementia, it's important to remember that they are not always responsible for their behaviors. They might not be doing these things on purpose. So the nurse aide can lay the groundwork for successfully handling situations when a resident is stressed and agitating, again, by really working on effective communication, learning your resident, and building those really important day-to-day trusting relationships. When a resident's unusual or inappropriate behavior escalates or increases quickly and becomes more serious, they may become dangerous to themselves and others. Sometimes the nursing care plan will include specific details about a resident's condition and special approaches. It's important to calm residents who are agitated in de-escalation. And if we find something that works for our residents, if we identify a trigger, if we learn something that works really well for that particular person in de-escalation, be sure to share it with the team and get it added to the care plan. So it's worth repeating. Great day-to-day relationships are really at the heart of de-escalation.